We often think of children's hearts as, inherently healthy, just beating away perfectly.
Hmm.
But actually, heart conditions babies are born with are more common than you might expect.
That's right. And today we're focusing in on one of these specifically, ventricular septal defects. You'll often hear them called VSDs.
VSDs,
Yeah, and a VSD is basically an opening, a hole in the wall separating the heart's two lower chambers, the ventricles.
and it's congenital, so they're born with it.
Exactly. And our aim with this deep dive is really to give you a clear, high-yield overview, perfect for revision.
So we'll cover what they are, the causes, the effects, how they're managed,
Yeah,
the key stuff,
precisely. We're working from some revision notes here, aiming to pull out the critical info.
making it easy to grasp, maybe with a few memory aids thrown in.
Yeah.
So this is your efficient VSD rundown.
Let's jump in.
Okay, so let's start with the basics. What exactly is a ventricular septal defect?
Well, fundamentally, it's a structural defect in the heart, an abnormal opening, a gap in the septum. That's the wall dividing the left and right ventricle.
Right, the lower chambers.
Exactly. And this opening allows oxygenated blood, which should be going from the left ventricle out to the body.
To mix with the deoxygenated blood.
Correct. It crosses over into the right ventricle, mixing with the blood that's heading towards the lungs.
And why is that mix a problem, clinically speaking?
Well, it affects how much oxygen actually gets delivered around the body.
Right.
And the impact, the consequences, they really depend on how big that opening is.
Okay. And are there different types?
Yes. We classify them based on where they are in the septum. So you might hear about membranous VSDs. They're pretty common. Or muscular, subarterial, infundibular, inlet, or AV canal types.
Right.
And just briefly, it's worth mentioning VSDs can sometimes be acquired, maybe after a heart attack, but honestly, the prognosis there tends to be poorer.
You said membranous is common. Just how common are VSDs overall in kids?
They're significant. VSD is often quoted as the second most common congenital heart defect overall.
Wow.
Yeah, and some sources even say it's the most frequently diagnosed one in children. And usually it's found in that membranous part of the septum we mentioned.
Okay, so an opening between the ventricles, blood mixes, different types based on location, and it's very common in pediatrics.
That's the gist.
Got it. And maybe a quick memory tip. For VSD, ventricular septal defect, think V for ventricle, S for septum, and the wall has a defect.
Nice one. Hopefully that helps it stick.
Okay, let's move on to causes. What's the etiology here? Why do these happen?
Yeah, the exact cause. Well, it isn't fully nailed down. The general thinking is it's likely a mix, a combination of genetic factors and environmental influences during heart development in the fetus.
So nature and nurture, in a way. Can you expand on the genetic side?
Sure. Certain genetic syndromes definitely carry a higher risk of VSDs. Down syndrome is probably the most well-known example. And then from the environmental angle, exposures during pregnancy matter. Things like maternal infections, rubella is a classic one, especially early on, or certain medications the mother might need to take.
Are there specific genetic conditions besides Down syndrome that are strongly linked?
Yes, absolutely. Chromosomal disorders often come up, so that's abnormalities in chromosome number or structure. Think trisomy 18, which is Edwards syndrome, trisomy 13 or Pethouse, and as we said, trisomy 21, Downs. Also, things like 22q11, deletion syndrome, and Turner syndrome.
Right.
And that's why if a VSD is picked up on an antenatal ultrasound, fetal karyotyping, checking the baby's chromosomes, is often discussed.
That makes sense. What about single gene problems?
VSDs can also be part of single gene disorders. These result from, mutations or deletions in one specific gene. And these often carry a higher recurrence risk in the family for first-degree relatives. Holt-Oram syndrome is an example there.
But do these specific syndromes account for most VSDs?
Actually, no. The majority of congenital heart defects, including most VSDs, are thought to be polygenic.
Polygenic.
Meaning it's a complex interaction of multiple genes plus those environmental factors. And right now, there isn't specific genetic testing for those polygenic causes.
I see.
But understanding the recurrence risk, which is estimated around 3 to 5%, that's still important for genetic counseling for families.
Okay. Any other maternal factors during pregnancy we should know about?
Yes, maternal diabetes during pregnancy is associated with a higher risk. And there's also suggestion that fetal alcohol syndrome and maybe even maternal cannabis use could be contributing factors.
Yeah, it really is a complex picture. Genetics, environment, maternal health, all potentially playing a role.
Definitely.
Which brings us nicely to summarizing the key risk factors. Can we boil those down?
Let's try. Key things to remember are maternal infections during pregnancy, like rubella, known genetic syndromes in the baby, especially Down syndrome, advanced maternal age, usually considered over 35, and mother's exposure to certain medications or infections while pregnant.
Okay, clear summary. Another memory aid, perhaps. How about MAGI? M for maternal age, G for genetic syndromes, M for infections during pregnancy.
MDI. Good one. That could work.
Hopefully helpful.
Yeah.
All right, let's get into the pathophysiology. What's actually happening inside the heart with a VSD?
So the core issue is that abnormal connection, the hole between the ventricles. It lets oxygenated blood from the left side.
High pressure site.
Exactly. The high-pressure left ventricle flow across into the right ventricle, and there it mixes with the deoxygenated blood returning from the body.
Okay.
The result is that more blood than usual gets pumped into the pulmonary circulation towards the lungs.
And what does that extra blood flow to the lungs lead to, sort of immediately?
The main worries are, 1, an increased risk of pulmonary hypertension, that's high blood pressure in the lungs arteries, and 2, just an increased workload for the right ventricle. It has to pump harder to handle that extra volume.
And if that goes on long term, what are the effects down the line?
Well, over time, that constant extra volume can make the right ventricle get bigger. It hypertrophies. And the high flow and pressure in the lungs can damage the pulmonary blood vessels, making them thick and stiff.
Which makes the pulmonary hypertension worse.
Exactly. It's a bit of a cycle. And if it's significant and untreated, eventually it can lead to heart failure.
So that aha moment is realizing the heart's working overtime to push extra blood to the lungs, and that strain causes problems later on.
Precisely. It's that extra volume and pressure load.
Got it. Now, when a doctor suspects a heart issue in a child, VSD is one possibility. What else might be on their list? What are the differential diagnoses?
Good question. There are several other heart conditions and even normal sounds that need considering. Key differentials include atrial septal defect, or ASD.
Hole between the top cameras.
Right. Then patent ductus arteriosus, PDA, that's a persistent connection between the aorta and pulmonary artery. Also, tetralogy of Fallot, which is a more complex set of 4 defects. And importantly, you have to consider innocent physiological murmurs. They're really common in kids and aren't a sign of disease. And maybe pulmonary stenosis, a narrowing of the pulmonary valve.
So it's not always straightforward just from listening?
Not always, no. That's why a really careful assessment, listening closely to the murmur characteristics, plus the investigations we'll talk about, are crucial to differentiate a VSD from these other conditions.
Right. Thoroughness is key.
Yeah.
Let's talk epidemiology then. How often do VSDs actually occur?
The estimates vary a bit, but it's generally around 2 to 6 cases per 1,000 live births.
That's fairly common then.
Yes, it's definitely one of the more common congenital heart defects.
And among all childhood heart conditions?
It's usually cited as the most common one diagnosed in children. It's found in about half of all kids with any congenital heart disease. And for about 20% of those, the VSD is the only heart issue they have an isolated VSD.
The notes mentioned the incidence seems to be going up. Why might that be?
Yeah. That's likely due to better detection. Advances in imaging, especially antenatal ultrasound.
Picking them up before birth more often.
Exactly. And also improved screening after birth contributes. We're just finding more of them, particularly the smaller ones, perhaps.
Interesting. What about adults? Is it still common later in life?
Surprisingly, yes. If you exclude bicuspid aortic valve, another common-ish congenital issue, VSD is actually the most frequent congenital heart defect found in adults.
Really?
Yeah, often these are smaller ones that maybe never caused symptoms or weren't picked up in childhood or didn't need closing.
Fascinating. Okay, let's move to clinical features. How does a child with a VSD actually present? What signs or symptoms do we see?
It really hinges on the size of the defect. Small VSDs, often completely asymptomatic.
No signs at all.
Pretty much. The baby feeds fine, grows well. The only clue might be a harsh systolic murmur that a doctor or nurse picks up on a routine check.
Okay, so the murmur is key for small ones. What about moderate or large VSDs?
Right. These tend to show symptoms a bit later, maybe around 4 to 6 weeks old typically. You'll likely hear a louder, harsher murmur. But also, the baby might sweat a lot, especially during feeds.
Sweating while feeding.
Yes, it's quite characteristic. They might get tired easily, show signs of potential heart failure. You might see they can't tolerate exertion, like feeding becomes hard work, difficulty feeding, breathing fast, tachypnoea, increased breathing effort.
And growth.
Poor weight gain is a big red flag. That suggests significant impact, potentially heart failure. And these babies might also get more chest infections, recurrent respiratory infections.
That sounds much more worrying.
Hmm.
And very large VSDs.
Similar symptoms, but usually more severe and might start earlier. There's a higher risk of developing pulmonary hypertension sooner. And in really severe large defects, the pressure can build up so much in the lungs.
That the flow reverses.
Exactly. Blood flows from the right ventricle back to the left. That's called Eisenmenger syndrome. And that leads to cyanosis, the bluish tinge, because deoxygenated blood is getting into the systemic circulation.
Okay, that's the extreme end. What specific signs might a doctor find on examination?
Well, for the small ones, like we said, healthy baby may be pink, just that harsh systolic murmur at the left sternal edge.
And for bigger ones?
With moderate or large VSDs, you might feel a more forceful heartbeat at the apex, an enhanced apical impulse. Maybe a peristernal heave, a lift along the left side of the sternum. The murmur is usually loud, harsh, often pansystolic, lasting all through systole at the lower left sternal border.
Any other sounds?
You might hear an extra heart sound, a prominent S3. Sometimes a mid-diastolic rumble, which suggests high flow across the mitral valve. And if there's pulmonary hypertension, the second heart sound, S2, might be loud and sound single instead of split.
Is it possible to have a large VSD without a loud murmur?
Yes, interestingly, in very large defects where there isn't much pressure difference, or if Eisenmenger's has developed and the shunt is right to left, the murmur can actually be soft or even absent. But the classic sound for a significant VSD is that loud, harsh, pansystolic murmur.
Okay, so summing up the key clinical clues for diagnosis.
You're looking for that loud, pansystolic murmur at the left sternal border, tachypnoe, fast breathing at rest or feeding, and failure to thrive, especially with larger defects. But ultimately, echo confirms it.
Right, which leads us perfectly into investigations. Echocardiography is key, you said.
Absolutely. It's the cornerstone. Echo ultrasound of the heart gives us live pictures. We can see the VSD, pinpoint its size, its exact location, see how it's affecting heart function.
To check for other issues.
Yes, things like right ventricular outflow obstruction or leaky aortic valve. And Doppler echo lets us estimate the pressure in the pulmonary artery, which is really important.
What kind of echo is usually done?
Mostly transthoracic, the probe on the chest wall using 2D and Doppler. Sometimes, if the images are difficult, transesophageal echo, probe down the throat, might be needed. And 3D echo is getting more useful, especially for planning interventions.
Okay. What about an ECG, the heart tracing? What does that show?
ECG findings vary a lot with the VSD size and impact. Small VSD, ECG is often totally normal.
And bigger ones.
Moderate size, you might see signs of left ventricular hypertrophy, LVH, maybe left atrial hypertrophy, LAH2. Large VSDs often show biventricular hypertrophy, BVH, both ventricles enlarged, maybe with LAH.
And if pulmonary hypertension develops?
Then the ECG might shift towards the right side, right axis deviation, right ventricular hypertrophy, RVH, and right atrial hypertrophy, RAH.
Right. What about a chest X-ray, the CXR?
Again, it depends on the size. Small VSD, usually a normal CXR. Larger defects, you might see cardiomegaly, an enlarged heart silhouette involving LA, LV, maybe RV, and increased pulmonary vascular markings, suggesting more blood flow to the lungs.
And with pulmonary hypertension on CXR.
You might see big main pulmonary arteries near the heart, but the outer lung fields can look clearer, algigamic. The overall heart size might even look normal sometimes.
Okay. And lastly, cardiac catheterization. You mentioned it's used less now.
Less often for just diagnosing a simple VSD, yes, because echo is so good. But cardiac cath still has a role. It gives very precise measurements, exact location, number of defects if there are multiple, pulmonary vascular resistance, how reactive those vessels are to oxygen or drugs, and the exact volume of the shunt.
So useful for complex cases or planning.
Exactly, especially if there's concern about high pulmonary pressures or planning tricky interventions.
Got it. So a range of tools, but echo is king. And a quick memory tip for investigations. Think EEC, echo, ECG, CXR, your mainstays.
EEC, good one.
All right, let's talk management. How are VSDs treated?
Well, it's really tailored to the individual child. Depends heavily on the size and location of the VSD, whether they have symptoms and their overall health.
So what's the plan for those small asymptomatic ones?
For those, the great news is many close on their own, spontaneously. So the main approach is watchful waiting, regular monitoring, follow-up echoes, just to see if it's closing or staying small and causing no issues.
And if it's a larger VSD causing problems, heart failure symptoms, poor growth,
then intervention is usually needed. Typically, that means surgical repair to close the hole. For some types, like infundibular VSDs near the outflow tract, surgery might be advised even without severe symptoms due to long-term risks.
Is there medical treatment too?
Oh yes, medical management is crucial, either while waiting for surgery or sometimes instead of it if surgery isn't possible or needed immediately. This includes diuretics to manage fluid overload and heart failure,
Right.
high-energy feeds to help with growth, ACE inhibitors to reduce the shunt volume and heart workload, and sometimes digoxin to help the heart muscle contract more effectively.
And if a baby needs a lot of that medical support?
That's usually a clear sign they need referral to a pediatric cardiologist for assessment, likely for surgery.
What about closing them without open heart surgery? You mentioned catheter closure.
Yes, that's a really advancing field. Catheter closure can be used for certain types, especially muscular VSDs and some paramembranous ones. A device is delivered via a catheter through a blood vessel to plug the hole.
The benefit being avoiding major surgery.
Exactly, avoiding cardiopulmonary bypass. But there are risks too. For perimembranous VSDs closed this way, there's a risk of complete heart block because the conduction system is nearby. So, patient selection is key, following guidelines like those from 9C.
Are there other approaches, hybrid procedures?
Yes, sometimes for complex cases, like really large muscular VSDs in tiny babies, a surgeon might make a small opening to help guide a device into place, combining surgical access with device closure.
What about antibiotics to prevent heart infections, endocarditis?
Current NC's guidelines generally say routine antibiotic cover before procedures isn't needed for most people with VSDs. That advice has changed over the years based on evidence.
Okay. And follow-up is always important.
Always. Essential for everyone with a VSD diagnosis. To check for spontaneous closure, monitor symptoms, check how well treatments are working, look for complications, and assess long-term heart function, especially after any closure procedure.
So, to recap management. Watchful, waiting for small ones.
Right?
Medical support, diuretics, feeds, ACEI, digoxin for symptoms, and then surgical or catheter closure for significant VSDs, often within the first 6 months, if causing failure to thrive.
That's a very good summary.
Great. Let's move on to prognosis. What's the long-term outlook?
Again, it varies, depends on the size, symptoms, any other associated conditions.
But generally.
Generally pretty good. For small VSDs, the prognosis is excellent. Many close on their own, no long-term issues. For larger ones needing intervention, the outlook is usually very favorable too, with proper management.
That's good to hear.
Isolated VSDs, especially, tend to have an excellent prognosis. Follow-up is still needed, of course.
When might the prognosis be less positive?
The outlook worsens if significant pulmonary hypertension develops, or especially if it progresses to Eisenmenger physiology. That damage can be irreversible.
What about things like exercise?
Usually unrestricted for small VSDs with normal heart function. For adults with congenital heart disease, including repaired VSDs, specialist advice is needed for things like contraception and pregnancy.
Why is that particularly important?
Well, pregnancy carries risks for anyone with heart disease. With pulmonary hypertension, for instance, the risk of maternal mortality is very high. Contraception choices also need care, considering thrombotic risks. Often, progestogen-only methods are preferred.
So the take-home message on prognosis is mostly positive with early detection and management.
Absolutely. Timely and appropriate care makes a huge difference to the long-term outlook for most individuals with VSDs.
That's definitely encouraging. Okay, finally, let's quickly cover potential complications.
Sure. If VSDs aren't managed well, complications can include heart failure, pulmonary hypertension, arrhythmias, irregular heartbeats, growth failure in babies, and although less common now with current guidelines, infective endocarditis.
Are there specific complications linked to VSD type or location?
Yes. Paramembranous VSDs, being near the aortic valve, can sometimes cause aortic valve problems like regurgitation. Obstruction can occur in the outflow tracts. We've mentioned Eisenmenger syndrome as a severe late complication, and arrhythmias or heart block can occur, sometimes related to the VSD itself or as a complication of surgery.
So again, it highlights why timely intervention and follow-up are so critical.
Exactly. Preventing these complications is key for better long-term outcomes.
Okay, fantastic. Let's do a quick wrap-up of this deep dive on VSDs.
Sounds good.
We defined it, that hole between the ventricles mixing blood. We look at the causes, that mix of genetics like Down syndrome and environment. Covered risk factors using AGI.
Maternal age, genetic, infections.
Right. Pathophysiology, the extra lung flow, risk of pulmonary hypertension. We talked differentials, ASD, PDA, murmurs. Epidemiology, very common.
Just common in kids, yeah.
Clinical features vary by size, from asymptomatic murmur to heart failure signs. Investigations: echo, ECG, CXR, or EEC,
Echo being key.
management watching small ones, medical support, surgery, or catheter closure for bigger ones. Prognosis is generally good with treatment, and complications like heart failure or pulmonary hypertension are risks if unmanaged.
I think that covers the core points really well for revision.
Great. So while VSDs are common, understanding these details is crucial. And maybe a final thought for you listening. With cardiac imaging and interventions constantly improving, how might the way we understand and manage VSDs change even more in the future? Something to think about.
Definitely a field that keeps evolving.
And if you are revising for the MSRA or just want to solidify your knowledge, do check out passthemsra.com and freemsra.com for more resources.
They're excellent tools.